Hello guys, today we go to 5 topic and today we will talk about surgical operation, basic principles of perioperative preparation, postoperative period, strategy of accelerated recovery of surgical patients. Surgery, how you know, it is a term traditionally used to describe procedures that involve manually cutting or stitching tissue to treat disease, injuries, or deformities. However, advances in surgical techniques have made the definition more complicated, because sometimes laser, radiation, or other techniques are used to cut tissue, and wounds may be closed without stitches. Biopsy. A diagnosis is sometimes accomplished by doing surgery. A biopsy, in which a piece of tissue is removed for examination under a microscope, is the most common type of diagnostic surgery. In some emergencies in which there is no time for diagnostic tests, surgery is used for both diagnosis and treatment. For example, surgery may be needed to quickly identify and repair organs that are bleeding from injuries caused by a gunshot wound or motor vehicle crash. The urgency of surgery is often described by three categories: emergency, urgent, and elective. Emergency surgery in Russia, such as stopping rapid internal bleeding, is done as soon as possible because minutes can make a difference. In Russia, we are talking about 84 hours, less than 84 hours. Urgent surgery, more than 48 hours, but less than 72 hours. And there we talk about acute cholecystitis and cholecystectomy. And elective surgery, such as replacement of a knee joint, can be delayed for some period of time until everything has been done to optimize the person's chance of doing well during and after the surgical procedure. But we have another classification where we talk about emergency, urgent, and scheduled, and elective. And there, emergency surgery is required within 2-3 hours. Urgent surgery is required within 24 hours, and there we're talking about acute appendicitis and acute cholecystitis. Scheduled surgery is required within 2-3 weeks. For example, it can be appendicular infiltratis, what we wait before it will be abscess, and after we do the scheduled operation. And elective surgery is done at convenience of patient. And we have one bigger classification where you see the urgent, emergency, and semi-urgent operation. Ideal time to surgery, immediate break-in to extend lists of required, and there we talk hemodynamic instability, for example, bleeding and GS double to the chest or abdomen, and it's called next one. Emergency within hour, viscous perforation, vascular compromise, sepsis, for example, limb ischemia, diffuse peritonitis of tissue infection with sepsis, and abdominal compartment syndrome. It is NEST 2. Urgent within 4 hours, extremity compartment syndrome, ascending colonicitis, incarcerated hernia, craniotomy, ectomies. NEST 3. And urgent within 12 hours, bowel obstruction, localized peritonitis of soft tissue infection in needed of surgery, appendicitis, abscess not accompanied by sepsis, and open fractures. NEST 4. And semi-urgent within 48 hours, second loop laparotomy or acute cholecystitis. NEST 5. And semi-urgent within 72 hours, first debridement or burn cases. It is more open classification, and I please you remembering about this classification. It will be better for you and for me, because it's better, really. Cosmetic surgery is a type of elective surgery that is focused on enhancing appearance. And how you know, I am a plastic surgery and cosmetic surgery too. There we just working with beautification of organs. Minor surgery and minor surgery. I don't like this classification, but I need to tell you about this one. A distinction is sometimes made between minor surgery and minor surgery, but many surgical procedures have characteristics of both. Minor surgery, often involves opening one of the minor body cavities, abdomen, chest, and skull. Opening the abdomen is called laparotomy. opening the chest is called thoracotomy, and opening the skull is called craniotomy. Yeah, three cavities when we open, we call it Mayer surgery. Uh, it always can stress vital organs. The surgery usually is done using general anesthesia in a hospital operation room by a team of doctors. A stay of at least one night usually is needed after Mayer surgery, but some Mayer surgical procedures are now being done safely in an outpatient setting, whether that is a hospital or a standalone ambulatory surgery center. Mayo surgeries. Doctors consider many factors in determining whether a Mayo surgical procedure can be done on an outpatient basis, including the person's overall health and risk of complications, the complexity of the surgery, and whether a hospital is nearby in case the person needs to be transferred. And the minor surgery. Minor surgery, minor body cavities are not opened. Minor surgery can involve the use of local, regional, or general anesthesia and may be done in an emergency department, an ambulatory surgical center, or a doctor's office. Vital organs usually are not stressed, and surgery can be done by a single doctor who may or may not be a surgeon. Usually the person can return home the same day that minor surgery is done. The risk of surgery, that is how likely surgery is to cause death or a serious problem, depends on the type of surgery and characteristics of the persons. But what I want to tell you about the minor surgery, uh, um, when I study, every surgeons tell me that minor surgery never can happen. Yeah, minor surgery, because, for example, the bleeding after minor surgery may be so high that it will lead to vital organs stress. Yeah, because, and don't thinking about this classification. I don't like it, but in the books I have it, and I need to tell it for you. But remember that we haven't got a minor surgery. Okay, types of surgeries that have the highest risk include heart or lung surgery, of course, liver surgery, abdominal surgeries, prostate gland removal, mere operation on the bones and joints. Generally, the proper the person's overall health, the higher the risk of surgery. Some particular health problems that increase surgical risk include history of and risk factors for coronary artery disease, history of heart failure, history of stroke, or transient ischemic attack. Symptoms of chest pain caused by coronary artery disease, angina, undernutrition, common among older people who live in institutions, severe disorders of the lungs or liver, chronic kidney disease, weakened immune system, for example, because of long-term corticosteroid treatment, diabetes that needs to be treated with insulin, and obesity. Risks are often higher among older people. However, risks are determined more by general health than by age. Chronic disorders that increase surgical risk and other treatable disorders such as dehydration, infections, imbalances in body fluids and electrolytes, and particularly heart failure and angina, should be controlled with treatment as well as possible before an operation. Second, opinion for surgery. The choice to undergo surgery is not always clear. There may be non-surgical options for treatment, and there may be several possible surgical procedures. Thus, a person may seek the opinion of more than one doctor. Some health insurance plans require a second opinion for elective surgery. However, experts may disagree on which doctor should give the second opinion. Some experts advise obtaining a second opinion from a doctor. Yeah, sorry. Some experts advise obtaining a second opinion from a doctor who is not a surgeon to eliminate any bias towards surgery when non-surgical treatment is an option. The other experts advise that another surgeon gives a second opinion, believing that a surgeon knows more about the advantages and disadvantages of surgery than would a doctor who is not a surgeon. Some experts recommend establishing upfront that any surgeon giving a second opinion will not do the surgical procedure, so that there is no conflict of interest. Surgery through a keyhole. Technical advances now make it possible to do surgery with smaller incisions and less tissue disruption than occurs with traditional surgery. To do this surgery, surgeons insert tiny lights, video cameras, and surgical instruments through keyhole-sized incisions. The surgeons can then do procedures using the image transmitted to video monitors as guides for manipulating the surgical instruments. In robotic surgery, the cameras provide surgeons with a three-dimensional view and surgeons control surgical instruments from a computer. Keyhole surgery has various names depending on where it is done: laparoscopy in the abdomen, arthroscopy in joints, and thoracoscopy in the chest. Because it causes less tissue damage than traditional surgery, keyhole surgery has several advantages, including the following: a briefer hospital stay in most cases, often less pain after the operation, lower risk of infection at the operative site, early return to work, a tendency towards smaller scars. However, the difficulties of keyhole surgery are often underestimated by people undergoing the surgery and sometimes by surgeons. Because surgeons are using a video monitor, they are seeing only a two-dimensional view of the site on which they are operating. Also, the surgical instruments used have long handless and are controlled from outside of the person's body. So the surgeon may find that using them feels less natural than using traditional surgical instruments. For these reasons, keyhole surgery has potential disadvantages. Keyhole surgery often takes longer than traditional surgery, but I don't agree with this one. And more importantly, especially when a procedure is new, errors are more likely to occur than with traditional approach because of the complexity of keyhole surgery. People also should know that also keyhole surgery may cause less pain than traditional surgery. Pain still occurs, often more than anticipated. Because keyhole surgery is technically difficult, people should do the following: choose a highly experienced surgeon, establish that surgery is necessary, ask the surgeon how pain will be treated. The operation room. If the final preparations are done in the holding area, the person is then taken to the operation room. At this point, the person may still be awake, also groggy, or may already be asleep. The person is moved to the operating table, lit by specially designed surgical lights. Doctors, nurses, and other personnel who will be near or touching the operative thoroughly scrub their hands with antiseptic soap, which minimizes the number of bacteria and viruses in the operation room. For surgery, they also wear scrub suits, caps, masks, shoe covers, sterile gowns, and sterile gloves. Before the surgery begins, a time-out is held during which the surgical team confirms the following: the person's identity, the correct procedure and location inside of the operative site, available of and needed equipment, verification that appropriate drugs to prevent problems such as infection or blood clots, if needed, were given. Local, regional, or general anesthesia is used. The operation room provides a sterile environment in which the operation team can do surgery. The operation team consists of the following: chief surgeon directs the surgery, or number one or more assistant, yeah, number two, number three, surgeons help the chief surgeon. Anesthesiologist controls the supply of anesthetic and monitors the person closely. Scrub nurse passes instruments to the surgeon, and circulation nurse provides extra equipment to the operation team. In Russia, we call it she, anesthesiology nurse. The operation room typically contains a monitor that displays vital signs, an instrument table, and an operation lamp. Anesthetic gases are piped into the anesthetic machine. A catheter attached to a suction machine removes excess blood and other fluids, which can prevent surgeons from seeing the tissues clearly. Fluids given by vein, started before the person enters the operation room, are continued. And now I want to talk with you about perioperative period. It is very important to remember on this one. The perioperative period is the time lapse surrounding the surgical act. It is subdivided into three stages: preoperative, operative, and postoperative. They must fulfill specific actions to achieve their final objective. And there you see a picture: primary refer, preoperative phase, intraoperative care and surgery, early postoperative phase, post-acute care, and primary refer care and follow-up. If we talk about preoperative stage, it is the first stage of the perioperative period. Its objective is preparation of the patient for surgery. It's divided into two steps. And before I want to talk about this picture. Identification of patients at high risk of bleeding. Iron deficiency anemia, non-iron deficiency anemia, fibrinogen levels testing, platelet function testing. Substep 1: hospital admission. It should be carried out by trained administrative personnel. Its objectives are the demonstrative admission of the patient, their correct identification, and their hospitalization in the corresponding unit: general hospitalization room, coronary unit, intensive care unit, and others. There we talk about emergency department, for example, where the doctors and nurses need to understand to what department the patient need to go. Substep 2: control of preoperative studies. It should be carried out by surgery residents or planned surgeons with knowledge of the surgery to which the patient will be submitted. Its objectives are to control the blood tests required: blood count, hepatogram, ionogram, renal function, coagulogram, others. Pre-surgical cardiology studies, electrocardiography, others. Imaging studies, radiography, ultrasound, tomography, resonances, others. Material applied: prosthetic meshes for hernioplasties, mechanical sutures, other devices. Among others, spirometry, endoscopy. Operative stage or intraoperative. It is the second stage of the perioperative period, composed of three sub-steps. The goal is to successfully carry out the patient's surgery. It should be noted that once the patient is in the operation room, the protagonists of the surgical act should maintain the operation room asepsis. This not only includes avoiding bacterial contamination of the surgical environment, but also keeping conversations that are straightly related only to the operative procedure. This concept used in the aeronautical industry and applied moments before starting a flight is called cockpit asepsis. Substep 1: anesthetic induction. It should be carried out by an anesthesiologist and an anesthesia technician, together with an assistant if necessary. The objective is to perform the anesthesia required by the patient according to the procedure to be performed: local, regional, or general anesthesia. It will be a good practice for the surgeon to be present at this moment, not only to transmit tranquility to the patient, but also to offer help to the anesthesiologist in case of difficult intubation, and to be aware of drugs administered for anesthesia. The substep 2 is surgery. The objective of any surgical procedure is to solve the health problem that afflicts the patient. For this reason, the tactic must be clear, for example, laparoscopic cholecystectomy with intraoperative cholangiography, and also the operative technique, for example, French position. The tactic should be defined prior to the time of surgery. For example, patients with acute lithiasis, cholecystitis of 4 days of evaluation, early or late cholecystectomy. The technique is inherent to the operator and is given by experience and training. Substep 3: anesthetic recovery. It should be carried out by an anesthesiologist and an anesthesia technician, together with an assistant if necessary. The objective is to perform the anesthetic recovery of the patient. It would be a good practice if the surgeon could be present at this time to help the anesthesiologist in case he needs it. It also allows contact with the patient as soon as he regains consciousness. And the last stage is postoperative stage. It is the third stage of the perioperative period. The goal is to successfully complete the surgery and composed of two sub-steps. Substep 1 control during hospitalization. The objective is to detect early any sign or symptom of an immediate postoperative complication. The wound controls the course, the medication administered, analgesics, antiemetics, gastric protectors, antibiotics, antithrombotic prophylaxis. Diet and rest should be strict. Substep 2. Ambulatory control. At the time of hospital discharge should provide the necessary advice for the welfare of the patient, as well as schedule the day, place and time of the next consultation. The goal is to avoid and detect any immediate postoperative complication. And now I want to talk with you about complications after surgery. Complications such as fever, blood clots, wound problems, confusion, difficulty urination or defecation, muscle loss, and a deterioration in fitness, called deconditioning, can develop during the days after surgery. Fever that develops during the days or weeks after surgery has several common causes, including the following: lung problems such as pneumonia or collapsed lung tissue, urinary tract infections, blood clots in the legs or lungs, infections of devices, tubes, or drains that have been implanted. Drugs may sometimes cause fever. Another possible cause is inflammation in response to the trauma of an operation. The risk of infections at the operative site, DVTs and UTIs, can be decreased by meticulous care after surgery. The risk of pneumonia and atelectasis may be decreased by periodically breathing forcefully in and out of an handheld device and coughing as needed. Blood clots in the legs or pelvic veins, we call DVTs, occasionally develop after surgery, particularly if people lie immobile during and after surgery or have had surgery on their leg, pelvis, or both. The clots can dislodge and travel through the bloodstream to the lungs, where they can block blood from circulating through the lungs. As a result, the oxygen supply to the rest of the body may be decreased and sometimes blood pressure may fall. For operations that make blood clots particularly likely and for people who are likely to have to lie still without much movement, doctors give drugs that keep blood from clotting, such as low molecular weight heparin, or put compression stockings on the person's legs to improve blood circulation. However, anticoagulants may not be recommended for operations in which these drugs may substantially increase bleeding. People should begin moving their limbs and walking as soon as it is safe for them to do so. Wound complication may include infection and separation of the wound edges. To decrease the risk of infection, doctors put a dressing on the surgical incision after surgery. The dressing placed on the operation room is typically left on for 24 to 48 hours unless signs of infection, such as increasing pain, swelling, and drainage, develop. In osmosis, I found interesting picture what I like. There we see that wound complication postoperative, disruption of anatomical layers manipulated during surgery, wound disruption, evisceration, dehiscence, seroma, hematoma, abnormal communication like fistula, and wound infection like superficial or deep. I like it. The dressing includes a sterile bandage and usually includes an antibiotic ointment. The bandage keeps bacteria away from the incision and absorbs fluids that ooze from the incision. Because these fluids can encourage bacteria to grow and infect the incision, the dressing is changed often, usually twice daily. The wound and any drainage tubes, sutures, or skin staples are examined whenever the dressing is changed. Sometimes more often, occasionally infection develops despite the best wound care. An infected site becomes increasingly painful 1 or more days after surgery and can become red and warm or drain pus or fluid. Fever can develop. If any other symptoms develop, the doctor should be seen as soon as possible. Delirium, very interesting complication. Confusion and agitation can develop particularly among older people. Drugs with cholinergic effects such as confusion, blurred vision, and loss of bladder control. Opioid sedatives or histamine 2 blockers may contribute as may to little oxygen in the blood. Drugs that can cause confusion should be avoided in older people when possible. Difficulty urination and difficulty defecation. Difficulty urination and difficulty defecation are common after surgery. Factors that contribute can include use of drugs with anticholinergic effects or opioids while surgery, inactivity, and not eating or drinking. Urine flow may become completely blocked, stretching the bladder. Blockage can lead to urinary tract infections. Sometimes pressing on the lower abdomen while trying to urinate relieves the blockage, but often a catheter needs to be inserted into the bladder. The catheter may be left in place or may be removed as soon as the bladder is emptied. Frequently sitting up may help prevent blockage. People who do not have a bladder blockage may be given bad hand call by mouth to stimulate the bladder to contract. People who develop constipation are given smaller doses of opioids, pain relievers, and other drugs that cause constipation and begin walking as soon as possible, unless the surgery involves the intestinal tract. People who develop constipation can also be given laxatives that stimulate the intestines, such as bisacodyl, senna, or saskara. Stool softeners such as glucosamine do not help. Sarcopenia, loss of muscle and strength occur in all people who need bed rest for a long time. With complete bed rest, young adults lose about 1% of muscle per day, but older people lose up to 5% per day because they have lower levels of growth hormone, which is responsible for maintaining muscle tissue. Adequate amounts of muscle are important for recovery. Thus, people should sit up in bed, move stands, and exercise as soon as and as much as is safe for them. People who are not receiving proper nutrition are at increased risk of sarcopenia. People are encouraged to eat and drink. If they are not able to eat and drink by themselves, tube feeding or rarely parenteral feeding may be necessary. And the last about what I want to talk in, it is a strategy of accelerated recovery of surgical patients. And there we need to talk about ERAS, enhanced recovery after surgery associated. Consensus statements and guidelines are powerful tools that have been implemented across hospitals and healthcare systems worldwide to improve the quality of surgical care. The strong principles underlie the RAS concept, including its multidisciplinary and multimodal approach to perioperative care, and results of RAS implementation may all have contributed to the success and wide adoption of the initial guideline in improving patient outcomes. Subsequent iterations and adaptations of the initial ERAS guideline have been produced using various methodologies but have frequently used the initial consensus paper as a framework. There you see the three moments for what ERAS working. Postoperative, mid-thoracic epidural anesthesia analgesia, known as a gastric tube, prevention of nausea and vomiting, avoidance of salt and water overload, early removal of catheter, early oral nutrition, non-opioid oral analgesia, early mobilization, stimulation of gut motility, audit of complaints and outcomes. Preoperative, pre-admission counseling, fluid and carbohydrate loading, no prolonged fasting, no selective bowel preparation, antibiotic prophylaxis, thromboprophylaxis, no premedication. Intraoperative, short-action anesthetic agents, mid-thoracic epidural anesthesia analgesia, no drains, avoidance of salt and water overload, maintenance of normothermia, body warmer, warm intravenous fluids. Yeah, all of these lead to great care, perioperative care. Yeah, and all of these give us decrease of complications and increase speed of patients go away to the home. Thanks for your attention, guys, for this topic for finished, and see you on the practice. Bye bye.